So this is the little schema of what the testing looks like. You probably heard about the nasal smear and how it works. Okay, so let's go through this testing. Okay, first, the first question is, when you're doing testing, is it the nasal smear or is it a blood test? When somebody says I get tested, I want to test, right? The big difference is it a nasal smear or is it a blood test? A nasal smear looks for live virus. It's called the antigen. It's called the PCR test, right? And it's the one where I put the Q-tip in the nose, goes all the way to the back of the throat, okay? That's the one. Remember I told you before that the viral shedding starts 24 to 48 hours before symptoms, peaks about 1 day after symptom onset, and then starts going away. Usually it's gone by 12 days, by the way. Usually it's gone by 12 days. So when people are saying, well, Mark, when should I do the nose? I want to see if I've been exposed to that. So there's all different kinds of scenarios, but keep that in mind about viral shedding, right? And then the sensitivity of these in a mild disease, 60%, about 70% more severe disease. And then look what happens. If you're days 0 to 7, look at the numbers. But as soon as you start getting out to days 8 to 14, look at the numbers, they drop, right? So you get a big drop off because the virus comes out before you have symptoms, peaks on day 1 of symptoms, and then starts dropping off, okay? Now, where's the best place to sample? Okay, the lower respiratory tract, right down in your lungs, would probably be better. You're gonna get more live virus there. But the problem with that is you can't get it. You'd have to start saying, oh, patients, okay, hack and cough and do whatever you can. But the truth is, you don't want to do that. You don't want to do that for the medical staff. You don't want to put it in the rooms. You don't want to aerosolize that stuff because that's more of a medical procedure. And the finding of the virus, remember, we talked about this, right? So I just want to show you one thing. Look at this study. Look. If you find virus, it does not mean you're infectious. There are 2 studies now, 2 studies that showed that when you find virus after 7 to 8 days and you try to culture it, you try to grow it, make sure that it's viable, it doesn't grow. In other words, can you find viral particles? Yes, right? We talked about that. We talked about you might see it in an aerosol. We talked about that you might find it on fomite. We talked about that. But does it mean that it's actually going to be something causing infections? Not necessarily so, okay? So that's nasopharyngeal, right? Now, blood. I know you're saying to me, okay, Mark, you did the medical thing. I didn't do the medical thing. What are you showing this to me for? I just want to highlight something there. Look. Very, very important. Very important. So stay with me on this. It's really important, okay? You have a virus comes in. There's a cell called macrophage which sees it. That macrophage then starts producing signals that go to T cells. The T cells then do different things. They start making killer cells which try to attack it. They also stimulate B cells. The B cells do different things and they create antibodies. Why am I showing this to you? It's important for you to know the following things. 1, not everything requires an antibody. You can be protected from an infection by just your macrophages. You can be protected by infection by just your T cells. You could be protected by your infection by just your B cells, which is why you can have somebody that has infection and they don't show a lot of antibodies. So you're gonna say, oh, I read these reports about people said, oh, you got infection, but you didn't have antibodies, so you're still susceptible. Look, anything is possible, but what's medically probable, what's far more likely is that it wasn't just antibodies that got stimulated. It was also T cells. It was also B cells. This is called the difference between, I'll just tell you the terms, you can forget about it. It's called humoral versus cellular immunity. But all I want you to remember is there is a difference, and you can see that difference in how people are protected, right? Next, look at this study. Look, very important. In this study, patients with mild disease had 100% T cell response and 100% IgG response, okay? Patients who never had exposure, I'm going to talk about that in a second, but just stay with me on the top half here, okay? Look. What this means is that when you do the studies on immunology, you're going to see that there's T cells that are activated, that there are antibodies activated when you carefully study it. So when people say, oh, I heard you can get the infection, you don't get an immune response, that's not true. You're going to get immune response. Is it measurable? Is it obvious? Is it straightforward? Is it standardized? Do you pick it up easily on some of the tests? Okay. In general, you do pick it up on the test, but not always so, right? Next, I want you to look at this study. This is very, very important, okay? Patients who never exposed to COVID-19, okay, ready? These people took blood from 2015 to 2018. This is blood that was available for a research study that was done for other purposes a number of years ago. This is before coronavirus 2, the COVID-19, ever existed. It didn't exist. They tested their blood, right? And what they saw was 50% of them showed that their T cells were active, which means that there was enough overlap between the old coronaviruses, those ones I told you about that cause the common cold, and this coronavirus, which is why you're going to have people that get exposed and don't get any symptoms because their immune system already recognizes this, or they get mild symptoms, right? As a matter of fact, there was a study done on 2 patients with congenital condition called agammaglobulinemia. You can forget the name, but here's the message. Here's the message. These patients congenitally cannot make antibodies, and yet they had COVID-19 and they survived and did just fine. Why? Because it could be T cells, it could be B cells. There's other parts of the immune system that'll protect you, right? So it's not just antibodies, right? The blood test is the antibody test. Now look, these need ongoing validation, right? But right now there's really 2 types for that. But one thing I want to drive home to you is look. IgG, that's the long anti-antibody, right? When you look back at the old SARS infection, they showed that the IgG lasted for at least 2 years. The MERS, a related cousin, the IgG lasted at least 3 years, right? So when people say, oh, I heard you can get this infection, but you're not protected or else, look, anything's possible. We've got some of these case reports that possibly some people, for whatever reason, in the whole system of mutation in their immune system, something seem to get the infection again. I'm not denying that, right? It's not common right now, but maybe it's early on, maybe we'll see more of it. But what is clear is that everybody gets an immune response. The vast majority of people are protected once they get this infection, and that it is worth both knowing that, and as well as if we can ever get lucky for a vaccine, that would be very helpful for us to know, right? Now, one blood test is called the pinpricks, this is the lateral flow assay, and it has reasonable sensitivity and specificity, right? But a lot of tests are dependent on certain characteristics, which I'm going to get into. The other blood test is the Elisa test. The Elisa test is, in my view, more reliable. It's a quantitative test, and it's coming online, so I am using it. But like every other test, it has to be used again and again and again in different populations of patients over different time periods to get clarity on how effective and reliable it is, okay? So that's very important to keep in mind when you're looking at these tests. Now, this gets a little busy, so stay with me, but there's a point to this, okay? What this means is pre-test probability, the likelihood ratio, post-test. Now, this is an example for influenza. What it means is the following. Look, it's very important. If you think that the chances of somebody having something before you ever test them is low, then the test changes your opinion a little bit. If you think the chances of somebody having an infection are higher, then the test changes it a lot, right? So this is important. This is why you have to have a doctor, because what we do day in and day out with every test, a stress test, a cholesterol test, a blood pressure reading, a blood sugar reading, is we have to interpret it in the setting of the individual patient. How likely are they to have something? How important is it that this result makes this change in their treatment, right? That's what this is talking about. There is no perfect test. There will never be a perfect test in medicine. Every test requires a physician interpretation. There's no way around that, right? Now, some people do better with schematics, so let me just show this to you. Look. This is where somebody gets exposed to SARS-CoV-2. And what happens about a week before their symptoms, is you start getting a rise in those antigens, in the virus. It starts replicating. It starts increasing, right? And then you have the symptom onset right here, and all of a sudden your PCR is clearly likely going to be positive. Your nasal smear is going to show it to you, and you're going to hit that peak, usually about day 1 of symptoms, right? And then those antigens in general start dropping off, right? Can you recover viral particles for many weeks later? Yes, we've talked about that. Are they viable? Almost certainly not, right? What happens also is you start getting those antibodies coming up, right? And those antibodies start lasting out there, right? So there's a little bit of delay from when you have your symptoms until the antibodies come out. That's why we have that timing of when to do the testing, right? On the testing, I can guarantee you a lot of things. Huge number of had don't know it. Italy, Italian study showed about 40-60% of one town's population had the infection, didn't know it. Spain, they have data about a third of the population who tested positive have never had symptoms. I've had patients, some of you, who've declined testing. The other thing I want you to keep in mind is very important, very important. Case fatalities. Death is awful, right? I'm not minimizing it, but you need to know the following. We are not New York. We are not a nursing home. And the vast majority of people who get this infection will do fine, right? The vast majority, right? The fatality rate for influenza is about 0.1% of all infections. The SARS-CoV-2 right now has a range anywhere from 0.02 to 0.4, right? These numbers will keep going down. You'll read some of the newspapers say, oh, the case fatality rate is 5% or something like that. Look, that's only because they haven't tested enough people to really know that, right? And it will depend greatly. Remember we talked about if you're over age 80, right? That's the cutoff period when the fatality rates really go up significantly, right? So you have to know that number when you're thinking about how you want to behave, how you want to react to this, okay?